Welcome inside Brunch, and thank you again for being here. This morning we are looking at medicine. We are looking medically at the health of Trinidad and Tobago, and we're also looking at another aspect of what's happening here, which is the question of ISIS fighters coming back to Trinidad and Tobago. That will be the second part of my discussion. Attorney Yuri Saunders will be joining me, and the question is to whether we ban them from coming back to Trinidad and Tobago. The risks and as far as the law is concerned, what you can do in making someone stateless and what you cannot do. That will be in the second part of our conversation. The first part, of course, deal with a number of issues that confront us all. One, either it hits just directly or you know somebody who is a victim of it. I speak in the context of diabetes, one. I also speak of hypertension. And then, of course, the one that a lot of folks don't pay attention to but need to, the abuse of antibiotics. Those are the three topics we're talking about this morning. My guest is a very respected urologist. He is Dr. Phillip Ayoung-Chee. Thank you so much for being with us this morning.
Good morning to everybody. You've
been with us before, and I'm so glad that you took the time to come back. We also have a situation that we will be touching on, because those who know Dr. Ayoung-Chee and have read his information for a long time, he's an advocate on behalf of the public, has been for a long time. Among the many things he speaks to is the bureaucracy involved in the health system, how in fact we can minimize that and make it easier for professionals like himself to execute what is their main focus, which is good health to the public. So the question of ambulance in the health service and the reaction time vis-a-vis the gentleman who was on the ground for 45 minutes in San Fernando, we will get to that. I do want to start with something that's on the front page this morning of the Trinidad Guardian. It deals with a venue where the president of Trinidad and Tobago, President Anthony Carmona, was present, and he was along there with Dr. Varma Dialsing, who is the head of the medical board of Trinidad and Tobago. And Dr. Ayoung-Chee, the area that caught my attention is not just what the president the treasurer of the medical board said, which is to say that some practitioners are still accused of having sex with their patients, creating drug dependencies and performing unnecessary surgeries for profit, and he's asking them to redirect their attention, but more particularly in the area where he said, we see these things, we hear of them, but we don't have the power to do anything. I am surprised at that. What is the situation, to the best of your knowledge, vis-a-vis the medical board and their ability to rein in, as it were, bad actors in the medical profession?
Well, morning to the general public. Well, I must say it quite clearly that I've been a member of the medical council for approximately 2 months. I mean, it should have been longer, but the appointment was delayed, and it only lasted 2 months. At the very first meeting I went to, there was a problem, and I asked, well, what are we going to do about it? And to my surprise, I was told, we can't do anything about it. So I said, what do you mean we can't do anything about it? And I was told, well, the most we can do is write the party that is being questioned and ask for a statement. And if we get a statement, we can ask a few questions. And if we don't get a statement, we can't do anything. So I was very disappointed. I mean, thinking that I was put on the medical council, and I could have made a change.
But you realize that the medical council was toothless, is that what you're saying?
Yeah, I mean, to my surprise at that time. I mean,
was this not your knowledge before going in?
No.
In other words, I'm trying to find out if there is a charter, if there is a mandate for this organization that is there only on paper and you found out differently, or whether they never in fact had the power to do anything.
Well, they never in fact have the power to do anything.
Constituted
it's
without power.
It's basically a paper trail. I mean, you write me, and I write a letter back to the person. And the person may write back, may not write back. Okay? And that's the end of the situation.
So that experience you had in the council, which is the same, that's being articulated right now by the treasurer of the medical board of Trinidad and Tobago, is to say that it is a free run for a lot of folks because the bureaucracy and the time involved to even satisfy the toothless tiger before it goes to any place where action can be taken is so long and winding that effectively nothing is done. Am I clear on that understanding?
I would like to say that quite clearly, yes. I mean, I have a personal situation there, and I am told that it can't go any further because nobody has responded to it. to my complaint.
Mm-hmm.
So basically, it has been dormant since 2008.
So the laws would have to be changed, at least the empowerment of these bodies would have to change drastically in order for these boards to, in fact, bring anybody to heel.
Well, yes. I mean, the way I see it, the board right now registers doctors, and they can log complaints. To resolve complaints, I would say quite clearly, they can't resolve complaints because there's no the legal recourse to that. And technically, you have to be very careful because if you read the law of the medical board, there's only one thing that you can do. It's to remove the license from the doctor, which may be a drastic step.
That is the severest of penalties you can do.
That is the only penalty. Okay? So you have to be very careful based on the Medical Board Act at present, what you're going to do. Because, I mean, any minor infringement, are you going to just say, well, I'm going to take away a license?
One of the areas that was identified by the treasurer is that a letter can be put in your file, which normally no one likes to have a questionable letter in their file. Does that make a difference to a practitioner if, in fact, something is entered into his file? Does it make a difference? No.
Well, the answer is no, because I mean, at the end of the day, the medical board cannot do anything with that letter in your file.
Okay.
At least I hope that the medical counsel, I mean, the counsel is the authority. The medical counsel will at least inform the doctor that a complaint has been lodged against him or her. Whether the doctor responds is a different question. And the medical counsel cannot tell a doctor they got to respond. At the same time, the medical counsel cannot tell you because you did not respond, we are going to decertify you.
There are consequences. Because the only option they have is way too drastic, is what you're saying.
Yeah.
Dr. Phillip Ayoung-Chee, urologist, is our guest this morning. We saw that in the front of the newspaper. We both looked at each other and said, we've got to touch on that. Okay, thank you so much. Unfortunately, it is not far moving because, as you said, which is the same thing the report alludes to, is that they are, in fact, toothless. And in order for us to rein in bad actors in the medical profession, we are saying that these bodies must be given a lot more power. Is there any other body outside of the medical council that, in fact, can do something about bad actors in the medical profession?
You may want to take legal recourse. So,
it must be legal, yes.
If you think it's a criminal act. But most times the judiciary will refer it back to the medical board.
For them to look at it and only in the severest case to pull your license.
Yeah, but while we're talking about that, I must say quite clearly, something that has taken place within the last 2 years to make sure that, because a lot of people question whether a doctor is fit to practice. Okay? The medical board within the last 2 years have issued certificates to persons who have full registration. Right? And again, the medical board cannot tell a doctor the certificate has to be displayed in his office. Again, I'm not too sure why that is. So they are issuing the certificates. My advice to the public is that when you go into a doctor's office, you ask to see their certificate, which is year registered. So there's a big 2015 on it. Next year will be a big 2016 on it.
I see. Every year that license must be updated, must be renewed.
Right. It has to be registered every year.
Registered. Thank you very much. Registered every year.
And every year, if you are allowed private practice, you are entitled to have a certificate. If you're not entitled to private practice, you will not be given a certificate. So the public must be aware of that, and they go to a private doctor's office, ask to see their annual certificate.
All right, we're clear on that. I want to go into the primary area that we said we're getting together for, which is diabetes and hypertension. According to the World Health Organization, the global prevalence of diabetes in 2014 was estimated to be 9% among adults 18 years and over. The World Health Organization states that more than 80% of diabetes will be the seventh leading cause of death throughout the world. The average across the rest of the world is 7 to 8% percent of the population who are in fact suffering from diabetes. In Trinidad and Tobago, unfortunately, we are looking at 12 to 14% of the population having type 2 diabetes. My question for you this morning is TNT, does the general predisposition to any one ethnic group make them more vulnerable to diabetes?
Well, first of all, before I answer that question, I think we need to look general. In general, we don't talk about diabetes and hypertension. We add cholesterol, which is high fat levels, and obesity. Okay, so we shouldn't really talk about diabetes and hypertension by itself. So we need to put these four. And in terms of, in addition, there's the 5, cardiac disease. Right, so these 5 need to be put together in a group. Now, recently I heard a quotation that among adults over 40, 1 in 5 has diabetes, 1 in 3 has hypertension, 1 in 2 has high cholesterol or high fat levels. In terms of ethnicity, which is the question you asked me, there seems to be a push among East Indians to be diabetic, and there seems to be a push among Afro-Trinidadians to be hypertension. All right. Now, when I started medicine way back when, I was told that approximately 25% of the adult population has diabetes, hypertension, because at that time that's what we concentrated on. Then I heard it went to 30%, and now I'm hearing now that 40% of the adult population has a combination of diabetes, hypertension, and hypercholesterolemia, high fat levels. Okay, and I think it's all related back to obesity and our diet.
Hence the reason I asked you about the predisposition, just that we understand whether it is in fact there is a group that's predisposed to it or not, and then I would come to clearly what you said should have been the first question is the contributory factors to diabetes/hypertension. Yeah.
Well, I think that in today's scenario, I don't think we can use that old-time scenario where we see the Indo-Trinidadians are diabetic, the Afro-Trinidadians are hypertensive. Because I think it's now across the board, and it's all correlated due to our diet and obesity, right? So you can say it's kind of leveling the playing field, and we have to look at what we eat. Okay, and that is the main problem that we have in this country. No, I'm not in the forefront of diabetes or hypertension or cholesterol or cardiac disease, but I do interact with my patients because I think these are more important than a urological problem. So I tend to make sure my patients are well, because in no sense if they are not well and you're trying to cure a urological problem, right? Basically, you're not improving the life of the patient. So I interact with my patients, and it's interesting to know that every time you tell a patient, are you overweight? The answer usually is no. And then you ask the patient, yes, you're overweight. Do you think you're eating too much? And the next question is, Doc, I don't eat.
Let me stop you right there, because the BMI is one of the measures, the body mass index, and a lot of folks say like that BMI belong to Caucasian folks and not black folks, or not people of color. It does not belong to Trinidad and Tobago. Is the BMI a useful and proven chart to use in understanding this as far as the body weight, fat, and so on?
The answer is yes. Okay, the answer is yes. I mean, people like to. When it affects them, like to look for different reasons. And we as Trinidadians, we tend to always look for a different reason why something happens. You understand? In the good old days, our parents would tell us, you have no weight. I mean, you're looking sick. You need to put on some weight.
Eat something.
You understand? Right? That is how it used to be. Today's scenario, where how you can put it, manual labor is not that prevalent anymore. It's all mechanical. It's all sit down in the office. It's all computer. I mean, you don't need to run across your room to look for a photocopier. You just sit down in your desk and you press a button and a copy appears. Okay? So we are now leading a very sedentary lifestyle, and we got to change our diet. Okay. Now, I mean, we go into the specifics of it just now, but in terms of this food pyramid that we all learn about, that food pyramid has to change. Okay. In other words, we need to put more fruits and vegetables in that pyramid and reduce the amount of carbohydrates. And so far, I mean, I've looked at it, and I think I've seen one food pyramid has changed. But in general, the food pyramid has stayed the same. They're still telling you got to eat your carbohydrates. But do we need that amount of carbohydrates today in our lifestyle? The answer is no. Okay.
The fruits and vegetables that you're talking about, I know in parts of the world there is a push on a lot of the fast food outlets to include that. In because and it becomes a concern of the government because the cost the cost to the nation as a whole when you have so many people falling ill, loss of productivity and potential for the country and so on, and they're encouraging a lot of fast foods that they must include a lot more of the fruits and vegetables. Are you satisfied with the moves being made towards encouraging? A lot of folks say you don't want to interfere with private enterprise, so you don't want to go mandating things. But as I said, the cost of the society is usually so much. So high that governments are finding ways to tell businesses you must incorporate that. Do you find there's a thrust coming from medical association, from the governing bodies to tell fast food folks, hey, listen, rethink the way you package this, you cook this, and you have to include these foods and vegetables?
Well, in my normal way, I have a different take on it.
Please.
Okay. People need to understand the fast food places have a role. And the role is that you may be in a bind one day and you need something quick to eat. It's there. But it should not be your meal.
Staple.
Okay? So number one is that the public needs to stay away from the fast food places. And they will, economically, they will learn their lesson. But when you use the fast food places as your meal, your regular meal, you are encouraging them to continue what they're continuing.
You're paying a lot of money for that on the one hand, and you're going to pay a lot more money when you have to see about your health.
Well, exactly. So I'm saying people need to understand. I've heard people say that, why must I go and buy a fridge and a stove at home? It's easy for me to just go in one of these places, pay a $30 and get a meal. But there's a price in it, eventually. I mean, now in your youth, you may not see the problem. But once you hit 50s, you're going to see the problem. You
were very clear that if I extract from what you're saying, this is not something that anybody has to do, any government body, or any medical body has to do with encouraging the fast food outlets to change their way. You're saying the power is in the hands of the consumers. They have to decide, learn more about it themselves, and frequent or frequent less these places for fast foods.
Yes, I'm saying that. I have seen over the last 3 or 4 years, most groceries, for example, because the other one I'm going to hit also too is the freezer foods. Okay?
Explain.
In terms of the microwave foods.
Yes.
Okay? If you look at the supermarkets over the last 3 or 4 years, they have all revamped. And revamped in the sense of putting in more fridges and freezers to sell these packaged foods, which is very convenient. Again, you buy it, you stick it in the microwave, and in seconds you get food. But is it healthy? We are still a country where we have access to fresh fruits and vegetables. Okay? Yes, it's going to take a little while in terms of preparing your food, but I have a little, as a student, I went recently, 10 years ago, back to England to do a course, and I cooked my own meals. All right, and not only was it cheaper, I'm sure it's more healthy. All right, and I enjoyed it, and it didn't take much time out of me. All right, so people need to relook at how their lifestyles are, and say, listen, do I want healthy food? What price am I willing to pay for it? Am I going to say the spending half an hour in the kitchen worth buying these fast foods or these microwave foods which has no nutrition, calories, and fats?
There's another thing, because when you talk about whether they contain what the contents are, a lot of folks don't really spend the time to do the reading of the nutritional information that's on a lot of the things that they buy, quick and in a hurry, the convenient stuff.
Well, I mean, I do have a problem because, I mean, I do indulge in it.
You don't, yes.
All right. I mean, yes, occasionally, and I want something quick to eat, I'll buy it. And I'm honest, I'll buy it. Okay. But as a routine, the answer is no. So I don't really care what these things have in it. I just avoid it on most times, except when I'm buying. Microwave foods, I'm totally against it. I don't have a microwave at home, and I don't intend to have a microwave at home. All right. I think we still have access to fresh fruits and vegetables, and that's how I will continue.
One of the good things I see is that the Minister of Agriculture recently asked that a lot of the supermarkets start paying more attention to local foods, and local foods, I assume, is going to include a whole lot of fruits and vegetables. So, yeah, the educating the public as to kind of what we're talking about this morning, because we are prompted on this, looking at the diabetic the numbers for diabetes in Trinidad and Tobago in 2014, but is the information being given out? Because there's a responsibility to educate people. Is the public being generally educated sufficiently, and they are ignoring it, or they're not being educated, is my inquiry to you.
Well, there are two things. I mean, the reason why I'm laughing right now is that recently I had an encounter with a patient, and I said to the patient, you need to eat more fruits and vegetables. And he said to me, well, I can't afford fruits and vegetables. I said, well, you're buying food anyway, and you're buying the wrong food. Buy more fruits and vegetables. And he said, turned around, and he replied was, you need to understand, I mean, you're rich. I mean, I'm not rich. I can't afford fruits and vegetables. So I said, what do you mean? He said, well, you could buy apples and grapes. And to the public out there, when they think about fruits, they think about apples and grapes. Now, I don't like apples, and I don't like grapes. All right?
I like Portugal. I tried to buy a stack of 5 the other day. It cost me $25.
All right.
It is
well, I mean, as I say, when you go to the market, for example, I mean, right now, I mean, I don't go to the market, but when I used to go to the market, what I did, the first thing I did when I go to the market, I scout around, right, and I buy what is reasonable on that day, right, and what is reasonable on that day next week may not be reasonable. Okay, so you don't have to go and say, I want X, and X is very expensive, today you're going to buy it. There must be something, there must be why there's a cheaper price.
A lot of folks listening to us here just want us to just tie in, I'm sure, what diabetes, what the major contributors are. You mentioned one is the diet, the other one is lack of exercise. Some folks believe that one is predisposed to diabetes. Can one be predisposed to diabetes, or is this a lifestyle thing that you're afflicted with, or is it hereditary, essentially, is what I'm asking?
Well, there's a small group who are prone to diabetes, okay, but it's a very small group. The majority of diabetes are due to what we call a chronic disease, all right, that can be controlled, okay, by diet and by exercise.
Cut down on the carbs and get moving. Do some exercise.
Right. And this is where the dietitians have to come and play. Okay. Again, I'm going to give my experience again. Patient comes, I'm talking to her about diet, and she starts to cry. So I said, why are you crying? I mean, I'm talking to you about diet. You spoke to the dietitian? Yes. She said, doc, you're not aware of what these dietitians tell you now. They tell me I can eat one hot dog, or one sausage, or one slice of cheese. But doctor, I can't afford one hot dog or one slice of cheese. I said, well, the aim here is one slice. Whatever you eat, one slice. She said, but the dietitian didn't tell me that. He said, I could only eat one hot dog, or one slice of sausage, or one slice of cheese. Okay? So dietitians have to be careful in what they're telling their patients in this format of a generic diet sheet. Right? And again, I will put it personal again. For breakfast, I eat one slice of bread. If you look at a diabetic diet sheet, it says 2 slices of bread. In other words, if I become diabetic, they're going to kill me. Understand? Because I cannot eat 2
You're
slices of
already on
bread.
the-
I gotta eat 1 slice. So they have to be very careful.
So I run the risk here because I was about to ask you, what is the diabetic risk checklist? Is there a checklist you would suggest for our listeners this morning, which kind of was halfway knocked down a moment ago when you said they've got to be careful about this template, the nutritionists. Is there a diabetic checklist folks should keep? Watch the carbs, do some exercise. What else?
Well, the first thing I would tell you is that you need to look at what you are eating presently. Okay? And again, I learned this from my mother who is diabetic. Okay? 10 years ago, she used to be testing her sugar every morning.
Mm-hmm.
And she would correlate the sugar with her diet from the night before. And if it was giving her problems, what she did was that she took it out of her diet. Right? Because she said, listen, I ate that last night. My sugar this morning is very high. I'm not going to cook it or eat it again. All right? So you need to look at what you're eating and cut back. First thing I want to tell you, you need to reduce your diet. So if you're eating 2 spoons of rice yesterday and there's a problem, bring it down to 1 spoon of rice. Or like patients say, I'm eating a little piece of roti. Well, cut that little piece of roti in half. Okay? Start eating less. That's the first concept. If you're not going to eat less, you're not going to lose weight, you're not going to control yourself. And then in that volume of less, put more fruits and vegetables. Let me retract that word more. Put a higher proportion of fruits and vegetables. Because when you tell a Trinidadian you need to eat more fruits and vegetables, it means they just throw more fruits and vegetables into the pot. Okay? You need to reduce volume and put a higher proportion of fruits and vegetables in that reduced volume.
Gotcha. Still trying to get over the 1 slice of bread, but that's a different issue. It is 30 minutes after 10 o'clock. Good morning. You're listening to Brunch. We are having brunch, and at the same time, we're talking about the health of the nation. We covered the area of diabetes, parts of the question of diabetes. But you did make the point, doctor, that they are no longer exclusive. They are tied together. So hypertension is a close friend that follows in this. Hypertension is known as high blood pressure. It is the leading risk factor of illness and death throughout the world. Over 30% of the adult population worldwide now have high blood pressure. 1 in 3 is not aware that they in fact have it. In Trinidad and Tobago, the situation is particularly disturbing when you look at the prevalence of high blood pressure in Trinidad and Tobago. Approximately 26% of the population, 29.8 male and 23.1 in females, or 1 in every 4 persons living with high blood pressure. Tell our listeners exactly what is considered high blood pressure and the cause of it.
There are no symptoms associated with hypertension.
Hypertension that's quite correct. It's against
Okay,
this.
let's be quite clear on it. Hypertension is called the silent killer. Okay, there are no symptoms, and I'm going to repeat, there are no symptoms associated with hypertension. The only way you can diagnose hypertension is you need to go to the doctor, get that blood pressure cuff on your arm, and get your blood pressure recorded. Okay. A lot of people have this concept that they don't have high blood pressure because they're not getting headaches and they're not getting neck pain and back pain. And I'm not too sure where that came from and why that is being associated with hypertension. It is not associated with hypertension. Okay? And even if it's associated with hypertension, it is associated maybe the end stages of hypertension. And that is not the level that we want to create. We want to get you at the early stage where we can put you on medication and control you so that you don't go into the complication stage. Okay? Now, I have a lot of patients also come and say, listen, I hear I have hypertension, but I do have a problem. And then you have the other scenarios that the doctor put me on medication. I went back to the doctor, he told me my blood pressure normal. So I said, so what medicine taking? Well, one time my pressure normal, so I stopped taking my medication.
Mistake.
You understand?
Major mistake.
The reason why your blood pressure is normal is because you're taking your medication.
You're pharmacologically in line. That's
exactly.
all.
Right? So to try to convince our Trinidadians of that is like telling them, I don't know what to do. You understand? It's like talking to air, because as far as they're concerned, The last time I went to the doctor, he might tell me blood pressure normal.
So 9 out of 10 times it's true to assume that if you are in fact being treated for hypertension, medically, with a prescription or pharmacologically, as you say, that you have to continue that regimen all the time for the most of your life.
For most of your life, yes.
If the doctor starts giving you medication for it, you can almost assume that it will be with you forever. You're not going to stop taking it.
Forever.
How often should one be checking for high blood pressure? I mean, how often? Like every day, every 2 days? Because one of the things that can happen is you can become paranoid. You're checking this thing too often. Twice and 3 times a day.
Well, at least, once per month, it should be checked. And you need to be guided by your doctor, who will decide now based on your blood pressure and how you're controlling it, how frequent they're going to see you.
And if you're diagnosed either borderline for it, or in fact, a victim of high blood pressure, then that is something you should check. What, once a day, once a week, what?
Well, once a day might be going a bit too far. For diabetes, maybe once a day, but for hypertension, I don't think you need to do it once a day. But at least it should be done on a frequent basis.
Give me some of the tips, Dr. Phillip Ayoung-Chee, who's my guest this morning on Brunch, some of the tips for maintaining a healthy blood pressure.
Well, as usual, diet and exercise. Okay? Everybody needs some form of exercise. All right? Usually, and I'm going to say this quite clearly, a lot of people believe now paying to go to the gym is the exercise. Okay? Most people go to the gym for social reasons, I'm going to say quite clearly, or to build muscles. All right? It is not cardiovascular. Okay, what you need is cardiovascular workout. And a simple means of cardiovascular workout is you go to work, don't use the elevators, don't use the escalators, walk. Okay? And that might give you enough exercise for the day.
Or park the car somewhere far from the office and just walk.
Right. Or park your car and don't go back to your car until the end of the day. Just to go to 2 streets down the road, you jump in your car to go 2 streets down. These are the kind of things that people do. All right? So there has to be some form of exercise regimen. And I don't mean going to the gym, but cardiovascular, to do some kind of cardiovascular as one. 2, in terms of diet. Again, the same principle. You need to eat less. Okay? Put a higher proportion of fruits and vegetables in that less. Okay, cut down definitely on the amount of fats. Okay, whether it's animal fat or your oil fat or your fried food. Definitely try to remove salt. Okay, our alternative to salt could be seasonings. We have so many seasonings in this country. If you put enough seasonings, you need to put salt in your food. Okay, but most importantly, what I find among us population is that we tend to spoil our foods.
Spoil it.
Yes, we tend to spoil our foods. For example, breadfruit, for example, is supposed to be a very nutritious food. Okay, but we spoil it by mixing it up with all sorts of things, and we call it oil dung and whatever. Okay, plain breadfruit is a good source of nutrition. But when you mix it up with these things, you spoil it.
You dilute. You dilute at best. You dilute it. Yes.
And while on that point, I want to say that similar with vegetables, we tend to fry up our vegetables. Okay, we don't need this raw steam. We tend to fry it up with salt and whatever, and mix up and spoil our vegetables. So we have to be very careful. Yes, you're eating nutritious food, but then you're spoiling it.
Yes. You compromise it before it goes in.
Exactly.
We're talking hypertension, we're talking diabetes this morning. The Ministry of Health is a vital outlet for educating the public. I ask you this in a different form. I'm going to get directly with it this time. Do you think the ministry is doing enough from what you have observed to inform the public as to parts of what we are talking about? Because it is absent that I thought we would have this discussion, because we keep hearing the reports coming that the numbers are up. We know that hypertension is the leading killer in Trinidad and Tobago. We know that diabetes is seriously above the average, and I don't hear folks talking about it. So I said, let me call up Dr. Ayoung-Chee. Let's talk about parts of this and see if we can bring some clarity to our listeners. By the way, listeners, we are opening the phones to you this morning in the area we're talking about. about. Telephone number is 628-2250, 628-2250, and 628-9107. So we're opening the lines for our conversation there. So I come back to my specific question. Is the ministry doing sufficient from what you have gathered to inform the public, to educate the public on exactly what we're talking about, the contributors to this and the alternative, and the fact that you're compromising all the wonderful fruits and vegetables you're having by doing your oil down or any variation of that?
Well, I think that when we're talking, we need to, in terms of education, we need to go into the schools.
Start in the schools. Yes.
We need to start at the schools. All right. And I'm an opponent. I'm saying this quite clearly, and I've written about it. I'm an opponent of the continuous assessment that is taking place in the SCA. Rather than and go through that continuous assessment and teaching about music and arts and whatever, which should be extracurricular. I think we should spend more time at this point in time where we're having a health issue to include health education in the primary schools and in the secondary schools. Okay? If you're going to clear the minds of people, you need to do it from the beginning. All right? And not get people into a bad habit. Let them know, hey, this is what you need to organize for the future. Health-wise, the diet out there is terrible. We need to change it. We need to show people how it can be changed. And you got to start with the kids. Okay? You cannot have kids who are addicted to fast foods as a primary meal. Okay? Again, I also oppose this program where you go to school and you get a free meal. Okay? In my time, I used to get up in the morning and I had to prepare my lunch to carry to school. Okay, so I knew what I was preparing.
But there are many families who don't have anything and they depend on that for the nutrition of their kids. Should we not instead be urging the body that provides the food, the free meal at school, to be way more mindful as to the content, the nutritional?
Right. Yes, we can do that. And also, I'm not saying that we don't provide free meals. There are needed people who will need free meals. All right, but it shouldn't be made as a given where everybody go to school and think that they're going to get a free meal. I'm open. I think people should get a responsibility in the morning when you wake up and you have a meal, you make your lunch and you take it to school. It gives you that sense of responsibility. It starts you thinking about nutrition. Okay? Rather than just going to school and you eat out of that box.
I got the bigger point, but I'm saying there are many families, as I'm sure you will agree, who cannot afford, they're unable to provide that. And that's why I said, let the attention instead be that the body responsible for providing the free meal, y'all just see about the nutritional side of it.
Right, but at the same time, I mean, yes, there are needed people, but I'm sure that you can show these needed people, right, how they can organize their limited resources in order to provide proper nutrition.
16 minutes away from the top of the hour. We have a number of other areas to go into. Just want to continue that. And we have also, outside of this, the diabetes and the hypertension, there is this question that has been raised many times. The socioeconomic pressure exerted on doctors by society, by parents to do something about a condition. We have gone kind of antibiotics crazy. There's an antibiotic used for everything. The abuse of antibiotics is something I wanted to ask you about. Dr. Phillip Ayoung-Chee is my guest this morning. How do we address this? I mean, what do antibiotics actually do? And why is it felt that it is the panacea for all ills, or for most ills anyway?
Well, it is not the panacea for all ills. I mean, it is a cure for bacterial infection. Okay? And what has taken place is that, I mean, there are two issues. There's a doctor issue and there's a pharmacy issue. All right, I know that the pharmacists are going to come down against me, but that's no problem. Okay? There are a lot of pharmacies out there who are prescribing antibiotics. Okay? Some of them under the guise that is being labeled antibacterial. Okay? But whatever it is, in that whole group, they are prescribing antibiotics and antibacterials to patients over the counter. Okay? And the public realizing that this is a quick way of getting something done without realizing what is the effect later down the road. Now, there has been no new antibiotics created within the last 10 years. Okay? And what's going to happen is that we are going to run the problem if we start seeing multi-resistant strains. And we are seeing multi-resistant strains. For example, as a urologist, I see patients who have come to me because they have used so many antibiotics, they now still have the infection, it's not curing, you run this test and you realize it's multi-resistant.
Just to be very clear, listeners, this area of the resistance is why we walked into this area of abuse of antibiotics, because after a while there is a resistance that is built up, and if you have the resistant strain in your system, no matter what is being prescribed at a time when it's really needed for a bacterial infection, it will have no effect or very minimal return. Is that what we're saying?
Well, there's no minimal, there's no effect, because once you run your tests, and it's all become resistant. Okay, there's no point, nowhere to turn. You just gotta say, listen, I'm gonna try this and hope that there is a response. Okay, it might be one of the resistant antibiotics, but you got no choice. You gotta try it and just cross the fingers and say, listen, let's hope for a response.
The injudicious use, you say that folks are doing it over the counter, and in some cases, doctors are doing it. So these people are doing it against the backdrop of the knowledge that it is useless and or has a desirable result later on. They're still doing it. Is there any way that they can be reined in, this abuse of it can be reined in, whether it be from the pharmacy standpoint, doctor standpoint?
Well, there are regulations, I mean, in terms of the doctors, there's very little you can do. Right, you just hope now that when they go through medical school, they are told the appropriate use of antibiotics. I mean, Dr. Bratt will support me on this when he says now that over 90% of infections in children are viral.
Right.
But over 90% of children get antibiotics.
That is the point, because folks have a simple thing like coughs and colds, and you hear about antibiotics being issued, and one is a virus is against a bacteria.
Well, a virus is something that gives you a limited infection. Okay, a bacterial infection can go on to more complex consequence. A viral infection can too, but very minimal. A bacterial infection will, if not treated, will lead to problems. So you got to treat a bacterial infection. Okay, but as I said, over 90% of infections are viral. All right, and you got to wait out that period and see. I mean, I'm not saying that if the patient is very, very ill and you're worried that it can be viral, but a serious viral infection, that you withhold antibiotics from them. All right. If you're worried, yes, you need to prescribe antibiotics. But we need to look at how much antibiotics are prescribed and how it is being sold over the counter. The over-the-counter part, I know there are regulations for it.
But are they enforced?
Like anything else in this country, the answer is no. Okay, I mean, it's a free fall until it affects somebody, and then we get a reactive response.
And the reason we're raising it again here on Brunch this morning is that folks understand that for every nice there's a price, and we are trying to just make folks aware that by doing this, while it may be a short-term solution, you could be putting yourself in greater danger for later on, because it is not something that is being speculated upon. This is proven that, in fact, the abuse of antibiotics will invariably, develop a strain that will not give you any relief when you really need it. That's what we're saying.
And yes, antibiotics do not increase the response time of a viral infection. Okay, so the only role of antibiotics in a viral infection is going to create a resistant strain. Okay, so there's no positive response or no positive effect of antibiotics in a viral infection.
Interesting. I just wanted to clear on that folks are very clear that they don't go over the counter and try to self-medicate, because that is a problem I'm sure that is a big one in Trinidad, the whole question of self-medicating. A lot of folks believe I can get it over the counter. A friend of mine told me this. I'm going to get antibiotics for this.
That is where the problem is. My friend had a similar problem, and they use antibiotics. So therefore, I should use the antibiotics. To go to the pharmacist and say, a patient came yesterday with the same problem and they had this antibiotics. Let us use it today. And that's how it goes.
Very clear on that. Let us go into the question of the, and this is the thorny one. I sort of left it for last because it is a thorny one. Thank you so much for your clarity on a number of these issues, which is diabetes and hypertension, and the question of abuse of antibiotics. The situation where a gentleman in San Fernando fell ill on the sidewalk, laid there, according to reports, for 15 minutes. 45 minutes, 15 minutes without asking someone to help. Which is to say, the wife of the victim said that the police officers that she pleaded with for 30 minutes. So he was laying there for 15 minutes. Then she pleaded for additional 30 minutes. Nothing was done, and ended up with the mayor leaving his statutory meeting he was attended, coming down, calling somebody from one of the municipal workers to, in fact, take the patient to the hospital. The question of ambulances, the head of one of the organizations, the organization chartered to provide buses to the hospital, said the problem we have is that a lot of the ambulance, when they get to the emergency center, getting the patient off and getting them in, the length of time that is taken there is a limitation for that. One, do you accept that? Two, I have seen where you've spoken on the question of the availability of assistance to the public, and ambulance is a serious area. What is your comment on that whole situation? One, of a man being there for 15 minutes, officers are told to, assist. They say we can't do that. It is reported it's not part of our job. The man stays there for 15 minutes before an ambulance gets there, and the place is just across the street.
Right. I mean, that's the first thing I want to make. I mean, based on the picture I'm seeing, he was directly in front of the San Fernando police station. He was across the street from the hospital, and he was on a car park of the San Fernando City Corporation. Mm-hmm. Okay. That's one. Two, and I think this is what concerns me, and I think we have to be very careful. Yes, somebody said it was 45 minutes. Mm-hmm. And then somebody said, no, it wasn't 45 minutes, it's 30 minutes. And now I see official report says no, it wasn't 45, it wasn't 30, it was 24 minutes, 27 seconds. Rah. And I am not happy. Mm-hmm. And I'm going to say quite clearly a name I'm going to call, which I think you're familiar with, Joan Rivers.
Yes. The
question of the death of Joan Rivers was did the ambulance respond in 5 minutes?
A TV personality who went ahead to do one of her number of surgeries, ran into complications, and the response time is what is being challenged. That's what the
5
doctor is
minutes,
speaking to. Yes.
Right? No. So that's one. So people have to be very careful in what they're saying. I mean, the response time should be 5 minutes. So what we need to find out from the authorities is what response time were we targeting, and was that within the target period? Don't celebrate because it's not 45 and it's not 30, but it's 24 minutes, 27 seconds. Mm-hmm. That's number one. Number two, I am concerned of the statement that we do not have enough ambulances. All right? That we have 42 ambulances in Trinidad. Mm-hmm. And we are hoping to get 25 more to bring up the fleet. In other words, is there some plan where we replenish the stock? Or is it that we wait until it reaches a low level and then just buy in bulk again?
So there's 45 for 1.3 million people is what we're
42.
saying. 42. Mm-hmm.
Yeah, there's 42 ambulances. There are politically, there are 39 constituencies, if you want to look at it that way. Mm-hmm. All right. Mm-hmm. So is there a plan where there's an annual basis whereby we buy ambulances to replenish the stock? Okay? And I also saw in another article where the fire service said, well, look, nobody called us, we have ambulances, and we could have responded.
And we have medical personnel who will accompany these ambulances, yes.
And in July and August, we got 25 ambulances to add to the 4 that we had previously. Mm. So in other words, the fire service went down to 4, and now they get 25 to go to 29. Mm-hmm. So in other words, there seems to be no rolling stock replenishment. We just buy in bulk at some point in time.
Albeit for a short space of time. You were a member of the medical council. Was this an issue, by the way? Then is that something that was looked at?
Well, the medical council,
specifically
they don't really deal with.
They don't. Okay, so please go ahead then. Yes. Yeah. Okay.
All right. So So I'm not too happy in terms of what has taken place. I mean, am making my comments based on what I've read in newspapers. All right, but it needs to be addressed. The problem, as usual, is that it's always a reaction and not a proactive measure. Okay, and it happens in all aspects of our life in Trinidad and Tobago. We don't look at maintaining. We wait until things reach to the crisis level and then try to replenish, rather than have a rolling stock to make sure that we at a certain level. Okay, I mean, same reference to the fire service again. There was a fire in Couva, if you remember. There was no fire tender in Couva. The fire service response, well, we did respond from Savonetta. And then we found out now that there are 7 or 8 fire stations without a tender. Why?
I want to go to the question of the police officers that the victim's wife said that she appealed to, and they said, no, we can't do that. Is there something that prohibits that? Is this a question of CPR? Should they have done exactly what they did to stand back? Otherwise, they can make the situation worse. Should they have called for a police vehicle? I mean, what?
Well,
what are they supposed to do? And I'm not trying to make you an attorney here. I'm just dealing. Yeah. We got one coming up to talk about ISIS, a separate conversation in a minute. So let me just stay on the area of, from a medical standpoint, bystanders and so on. Somebody seeing the situation. Should somebody have gone to administer CPR? Should the police have done something? Should the family have attempted to move the person, or a bystander just decide to stop his vehicle, take them, and take him there? I mean, what is the best advice when you see a situation like that? I'm cognizant of what we're talking about. The system has to better equip itself. But in the case of people who were just around, who say, why didn't anybody do something? What could they have done? What is the best advice if you see that situation?
Well, I mean, I need to comment to this as a member of the public. Okay. Number one, as I said, it was directly in front of the police station.
Yes.
And therefore, I think that a police vehicle could have been sent and tried to move the guy to the hospital, which is across the road. No, I think that would have been the easiest solution based on what I'm seeing and what I'm hearing. Okay. In terms of CPR, I mean, if you're comfortable with it, yes, but then you need to know, you can't just go and just start pumping a chest, if you want to use that word. Okay. You need to assess the situation and see exactly what is taking place, and make an assessment before you do that. And you need to be properly trained to assess the patient and to start CPR.
Well, it's an unfortunate situation, but we did spend a little time on the question of the ambulance, the replenishing of the ambulance. Are you saying that with 39 districts separating and 40, what is it? The number will go up to 49. Is it 49?
Well, is it 42? And hopefully they're going to get 25. So that'll take them to 42, 67. All right. And in the meantime, we don't know when that 25 is going to come. In the meantime, some of the ambulances are going to go out.
But people who were there, as you said, you don't know the state of the person. If the police, who I feel,
at the very least, I mean, they could have asked.
Could a member of the public have done anything there? Like, you're just driving by, you see this, you see the hospital right over there, pick the man up, carry him, take him, put it in your vehicle. Is that advisable?
Yeah, I would say no, unless you know exactly what you're doing.
It is not advisable.
It's not advisable.
Okay. So it's not good enough just to indict everybody who passed by and did nothing, because you must know what you're doing. Otherwise, you can make a situation worse. Is that correct?
That's correct.
All right. The normal. Thank you so much for taking the time with us. We have run out of time. 3 minutes away from the top of the hour. We covered diabetes and we looked at hypertension. The normal range of blood sugar. You mentioned how important that was. What should that be?
Well, the most accurate one will be a fasting blood sugar in the morning. You wake up in the morning without eating or drinking within the last 8 hours. It should be less than 110.
It should be less than 110.
Yes.
So a range of 80 to 110.
Yes.
And you're not doing too bad.
Yeah.
As far as eating, you say watch the amount of carbs. That's really important. You're saying that start exercising. Don't drive to the office or drive 3 blocks down the road. Walk 3 blocks down the road. Don't use the elevator, particularly if you're on one of the towers. You're up at the 40th floor here, right?
At least you can walk down.
Yes, you can walk down.
You can walk down.
Right. The gym thing is a good thing, but if you're going there to build muscles, you're saying this is not doing anything in the area of your hypertension. What instead you need to do is spend more time on the treadmill, because that, in fact, is going to give you the cardio. You need to do the cardio.
Yeah.
The cardio. So for the purpose of the hypertension we're talking about, the cardio is your best ally.
That's right.
All right. So the treadmill should be your first friend. And we can, of course, do that the cheap way, because it's expensive to be in a gym now. If that is your priority, you simply do that by doing a lot more walking around in all your free time.
Yeah, that's right.
All right. I got that. Doctor, any other advice you want to pass on to our listeners before we leave out here this morning?
Yes. The advice I would like to give to the general public is you got to eat less.
Yes. Eat less.
You got to eat less.
Quantities are too big.
I don't want to say anymore because people are going to mix it up. My few words: eat less.
Christmas is coming, and then Carnival is on the heels of it. A lot of big eating will take place, so that's timely advice. In addition to Carnival is coming, a lot of fast foods will be consumed.
Well, no, in this day and age where we have the bikini costumes, I think most people want to be looking fit and trim. So I think they need to eat less.
Well, that's an incentive. That's one good incentive. What do you call it? The bikini costumes?
Well, I mean, it's
dental floss outfits. Okay. Yeah. Essentially, Dr. Phillip Ayoung-Chee, thank you for taking the time this Sunday to be with us.
That's no problem.
A couple of areas we passed through at you, and it's always good to have you here.
Thank
you so much for your work and your contribution and looking out for the health of Trinidad and Tobago. Truly appreciate it.
Okay, thanks very much.